Okay, so this is actually one of my patients just recently came to our hospital to suspect, and can you show the stress for answer or the pooling sessions? Okay, so yep, 40% get it. Junctional readout with PSC, good. Okay, back to the ECG. Okay, again, everyone feel free to join in, yeah. Okay, so this one, okay, so this one actually is quite interesting because patient came with giddiness and syncope. So there's actually having dilemma in emergency itself whether this one is just a bradycardia. But when I look at it, I think it's more interesting because the first part actually you can see definitely obviously junctional rhythms because the red arrow showing the regularity of the uh, QRS, which is quite narrow, but there's no preceding P wave. But the second component, which is highlighted as blue arrow, is pointing to a negative P wave in the inferior lead 2, 3, and AVF, suggesting that this actually is a PAC with quite regular. So this is a junctional rhythm with PAC. So, okay, just a bit of junctional rhythm is originated from P wave, but I always, so far it's very, the good way to determine whether it is junctional or not to look at the regularity. If there is a regular, then it's more toward junctional rhythms. But then again, sometimes you might be lucky enough to see the retrograde P wave, especially in inferior lead, where you can see the P wave is inverted to suggest that there is a component of pacemaker coming from the junctional node and then it's retrograding going up. That's why you can see inverted P wave. Okay, maybe this part, anyone would like to add? Okay.
Actually, I just want to ask Ridwan, would you consider a differential of a junctional rhythm with an atrial echo? That means the junction, then it goes up the slow pathway, gives a retrograde A, and it comes back down the fast pathway for 1 beat, leaving the QRS. But of course, it's not in the answer, like just an open discussion.
Actually, it might be possible, but it's going to have a retrograde conduction, re-entrance conductions. It's going to be tricky because just to diagnose based on the ECG. But the best actually is just to look at the calipers and then we can see. But for I think it's going to be difficult just to determine. But what do you think?
I think you're right. It's definitely junctional because the rate is too slow. And it's quite unlikely that it goes up the slow pathway and comes back down the slow. But I mean, everything in EP is a possibility.
Yeah, unless we do EP, you stick a catheter in. Then
if for so long it didn't conduct, if it goes up, right? I think it would choose the fast pathway instead of the slow pathway. And then when it comes out with, I mean, an echo looks like this, but it's just not that long. That's what I feel.
But I think the point to away from that re-entrance because we expect to have a like at least maybe some manifestation of maybe conceal or manifest answer pathway. But then again, it's very hard to determine by just look at traffic ECG unless we can have a CS catheter. But if we're going to have a echo, for me, I cannot answer that to be honest.
Yeah, I don't think this one strict, but it's a good thinking process.
Yeah. Okay. So maybe next I'll pass to G.
Just now, right? Your questions, right? Whether it's possible echo, right? I mean, look at the second bit, right? I mean, I think maybe you're thinking like that, lah. Because the PAC, right? After the QS, there's one bump there, you know. But you look at it, the subsequent one, there is no bump, you know. The second arrow, they're pointing to the QS. Okay? It's quite clean, you know. So I think maybe lah. I mean, you're thinking of the echo possible or not. I think maybe the first one, yes lah. But subsequently, I think. Now you say EP is anything is possible, still possible, but a bit unlikely. So going back to the case 12, I think can we just have a look at the answer? So I think in this case, I think majority 63% got it correct, which is they got it as a VT, a polymorphic VT. Oh, okay. So I think in this case is quite interesting. I mean you can see that there is a bidirectional VT. So I suppose this patients is exercise-induced palpitations. So if in this case, most likely the resting ECG will be normal. then by looking at this, I think it clinched the diagnosis of a CPVT.
Okay, so again, this one because I think I haven't seen CPVT in my life, to be honest, and I think I got it from the classical textbook. But again, it's just pointing toward bidirectional because when we have bidirectional, the only things that might we need to think of whether is it like polymorphic, and then one of the common thing is actually CPVT, but how did it pick up? So CVT is actually more towards syncope during stress or emotions and bidirectional. Most of the time they have a such a normal heart as mentioned by Dr. G, and the genetic component may contribute to CVT such as RYR2 mutations. And the management, I think the management more toward beta blocker, but even if sometimes we might need to put ICD, but even if you put ICD, you might render them to have more shocks and you can have more mortality with having shocks. So that's why they have a few studies on left cardiac sympathetic denervations, which shows a promising result, but again, still not as a guideline because I think they need more study to determine that. So now we're going to case number 13. Okay.
John, can I say
Yeah,
something?
sure.
The ECG before, I think it's very good. I actually have never seen a CPVT. But these are bidirectional VT. Okay. So when you have bidirectional VT, there's only two diagnoses. As far as I know, there's only two diagnoses that you can have. Number one is CPVT, and number two is ditch toxicity. So if the patient is running and he gets bidirectional VT, then it's CPVT. If the patient is resting and the patient has bidirectional VT, I don't think you should diagnose it as a CPVT lah. Then the diagnosis, you should really look hard whether the patient is on digoxin or not.
Okay. So, oh yeah, I realized actually there's an escape bit here. So we can see a nice sinus wave. So with this, we're definitely going to clinch that this actually is CPVT. But I didn't realize that as well until just now. Okay, so case number 13, I think I'm going to open to discussion because I think this is, again, one of my patients. And I think I'm still having dilemma until now whether, what is it, to be honest. So we're going to shoot I think we're going to shoot a poll. Can we shoot a poll? What's the audience think about this ECG? Okay, good. So if you look at that choice of answer, I put junctional rhythm, isorhythmic aviation, sinus rhythm, or all the above maybe. And for me, I put all the above maybe because I want everyone to get involved with this. Okay, back to the ECG. Okay, again, feel free to interrupt because I think this, for me, is still puzzling for me until now. The one I highlighted actually is the RR interval is quite regular, quite constant, as highlighted with the blue line here. But the one I highlighted in the blue arrow is actually, I think is actually AV dissociations. That's why I think is junctional rhythm with AV dissociations. This is more to isorhythmic, just happen to increase the sinus activity, just happen to coincide with the QRS complex. But the one that puzzling is the purple one. Because I just wondering whether this actually is the sinus rhythms that manage to penetrate, which means that SA node just suddenly wake up with the one beat and then conducted to the AV node. I think that's why I would like to open to panel. What do you guys think about this one?
Okay. Faiz, you want to try?
Yeah. If you have isorhythmic AV dissociation, it's quite interesting because it means that the atrial is moving on its own and ventricle is on its own. But you need to, because based on our experience, this isorhythmic AV dissociation, they can have both actually. They can both have a sinus node and AV node disease. The purple one, you can see here, significant. That is a significant first degree AV block. So we are still not sure because this is first degree. Because we need to, if you want to further evaluate the AV nodes, you need to, it's either you put a stress test patient. So you need to increase the P wave. If you have a lot of P wave which is not conducted, and then this is due to AV node issue. But sometimes, as I said just now, this type of patient, usually you can have two. If you have, you want to stress test the patient, sometimes the sinus node also is not good. It cannot fire, the chronotropy is not competent. Okay, so but this is a good example. The good example, you try to pinpoint where is the lesion actually, whether this is sinus node issue or whether it is a AV node issue.
I have a disclaimer here. I think none of us, me and Faiz, we never saw this ECG.
Yep. Yeah, because this one I just keep
so
it as
just-
a surprise to everyone.
Yeah. Looking at it, but to me, so for me, I would just see what is normal and try to match it. Now, what is very obvious to me is the RR interval, except the purple bit, the RR interval is always the same. And the purple beat is actually conducted, there's a sinus beat that actually conducts through that. So you can see a P and then followed by a QRS with a PI interval, which is prolonged. And then if you match the P wave, that is actually, Redon has done it very well. The only one that he missed probably is this one. And you can see all the other P waves, right? Actually, there's no way that the P wave can conduct down because this one ends on a T wave, so it cannot conduct down. This one ends on also a T wave. This one ends before it, so it's functional. It cannot conduct down. So the only one that could conduct down is this one. So to me, this is actually probably the sinus node is diseased because if you march these two are you think is normal, right? This PP interval, and then if you march it, there's nothing actually there's no P wave that is formed. So for me, the sinus node is diseased, and the junction is kicking in. But if there is a P wave, then it will conduct down. For me, that is what I see from this ECG.
So that's why.
Nice thing.
Okay, that's why I think for what I gathered from the ECG, because I've been thinking for almost 2 weeks now. So, okay, so that's why I think actually is actually to be honest, this patient actually definitely have a sinus dysfunctions and also have AV node dysfunction because we can see the AV dissociations. But to say that actually AV dissociations for me is relatively because hard to say because this is what I think this actually is a sinus dysfunction is the main contributor for the symptoms. And it's just that the P wave sometimes conducted, but occasionally become the sinus dysfunction. They can have a slow sinus rhythms. But when they have a slow sinus rhythm, the junction rhythm take over. That's why the only purple things that can have a getaway, which means the normal intrinsic, which is the P followed by gyrus compact. But the rest, as Dr. Mi mentioned, is actually a functional because the junctional is because the sinus not too slow, the junctional take over. So I think that's the unifying diagnosis, and to be honest, patient end up with pacemaker anyway.
So I think for the benefit of the audience, this is one strip of ECG. In real life, actually we got the benefit that we can actually repeat multiple ECGs and actually hope that actually something actually happens. Like this, the P wave actually came in and conducted. So does it repeat or not? You can do few ECGs and then discern it, and then you be able to guess what is it like. Or the second option is you can send to us. Then we can do an EP study, then we can find out.
Okay, so again, let's show the pool now. Okay, so this actually ECG is actually based on true story, which is they forward to me asking about my opinion, and they actually thinking more toward again. They are most of the other side also thinking about ventricular rhythms. So let's go back to the ECG because there's a reason why I think it's about VT. Because I believe to determine VT, there's a few algorithms, Verike, Brugada, but both actually, I think the only unifying, I think the most easy to look for actually is AV dissociations. Because if you see more V than A, it's definitely VT. That's why for me, when I look at the ECG, first thing I try to look is try to find, is there any A or not? And how is the quantity, whether is it VIMBO or the A? So the things that are highlighted in blue, I think is this is P wave, because especially this part you can see the P wave, and not much atrial activity that you can see. So that's why I think it's one criteria is more toward VT rather than SVT or ventricular rhythm, okay, or S-rated. Another thing is pointing toward VT rather than S-rated ventricular rhythm because look at the QRS compact between both the one I highlighted in star and the one before and the one after. It's almost like an alternate. So they can have a QRS alternate, but at the same time they also have a T-wave alternate. Here, one before and then the one after. It's almost like a cyclic kind of thing. So when we have QRS alternate or T-wave alternate, we only think about reentrant tachycardia, and the common thing is more toward AVRT. But MVT actually is actually a micro reentrance tachycardia as well. They can have a reentrance, and that's why I think maybe this one is pointing more towards VT because of the I can see AV dissociations, and again even though it's alternate is more towards SVT, but they can manifest in VT as well. And the one thing I would like to highlight is actually, I'm not sure whether is it considered true or not, but I think the QS actually is relatively approaching to the criteria, but it's almost concordant. It's just like a pattern break kind of thing, where it's negative, positive, negative again. So that's why I just wonder whether it is. I think based on that, I think it's more toward VT. But again, open to discussion.
To be honest, I'm not sure, but I beg to differ a bit because let's say we look at V3, right? You can see this one. I mean, this and this, I clearly agree that this is alternance, and also the T, like what Dr. Rizal mentions, there's a T-wave alternate as well. But let's say we look at the history, right? This patient is CPR and then revive, right? I think the answer would be, I think it's a CPR. Then after that, this is all just electrical alternates caused by the post CPR. I don't think this is VT lah. I mean, my personal.
I actually have the luxury of having the full story. I didn't read the full story. Patient actually have bypass as well, post bypass. So that's why there's another thing because continuous TV. But again, it can be ventricular rhythms. But that's why I think because I have the luxury of having the full story. That's why I think I already have the point of having VT. But just by showing the ECG, I just wonder whether you have different ideas because I believe totally agree with Dr. Chi because sometimes it can be just a isolated ventricular rhythm, but the one that I want to highlight, maybe I would like to have a discussion.
So question is, for me lah, I see ST elevation in V1. So the question is, since patient is CPR, is it a MI or is it a current of injury that is post CPR? Of course, that is not pertaining to the question lah. I mean, I was just wondering lah, is it an ischemic event that causes it? Second thing is about AIVR. I assume AIVR is accelerated idioventricular rhythm. Accelerated idioventricular rhythm is used when your ventricular okay, so when you have a ventricular rhythm, you divide it into a few. One is ventricular escape, accelerated idioventricular, and ventricular tachycardia, all rate based. So if your rate is less than 60, then if I'm not mistaken, is 60, then you call it as escape because that is 40 to 60 is what the ventricular escape is supposed to be. Between 60 to 100, you call it accelerated idioventricular. Above 100, then you would call it VT. This rate, I think, would be under the VT category lah, because it's more than 100. The least is a bit wobbly, the RR interval, but the least that I can see is actually 3 boxes, and 3 boxes means 100. So for me, I would say it's VT lah. And also, why would the patient be VT? If the history is CABG, I would think of an ischemic event lah.
Yeah, rate is important when you have a ventricular rhythm. But to me, it's relatively slow for VT actually. Yeah, very slow. Yeah, can have scar VT that. But Dr. Rizwan mentioned that there is a P wave there. There is association there, dissociation, VA dissociation. All right. So there is definitely more V than A. Okay. AIVR also can behave like this. You can have the P wave, which is the P wave is less number as compared to KRS wave. So again, yeah, AIVR is I think is a solid differential diagnosis, looking at overall, and yeah, rate lah. Yeah, you can have that differential. You can say that the rate because of in the scar VT, scar VT can slow VT because of you have the scar there to re-entry around that. All right, but again, the most important thing, if you have doubt in this type of patient unstable, broad complex tachycardia, you need to put VT as your first diagnosis. because IVR is nothing. All right, it's most of the time it's nothing, but VT you need to do something. All right.
So I'll pass to you.
So I think this is the last question already before we say out the winner, right? So this one is the case. 18 years old girl without any medical illness came with palpitation. And just see the pool. Sorry. Oh. I can't see the last answer, but seems like it's like, wow, this is very interesting. Is what they call it, stuff? What? Stays? Whatever. So it's very interesting because it seems like it's almost like 1/3. Septogram, is it? Can go back to, can go back to the, yeah, you all can just ignore that. Okay, I think one thing interesting here is, I mean, this is a narrow complex tachycardia. Everybody can see. In terms of the retrograde P wave, I think this is quite clear. In terms of retrograde P wave. But one thing striking here is, in between, let's say you already can see, there are some isoelectric line here. So let's say you can see here, there's no P wave here. So in this case, let's say you match the V compared to the A, there's definitely more V than A. So if let's say you're talking about AVRT, definitely it's out because your AVRT, the atrial and the ventricle are just like husband and wife. So this is definitely out. The second thing about this case will be atrial tachy. So if let's say we zoom in at the inferior leads, 2,3 AVF, this is a negative retrograde P wave. So it's basically suggesting that this is from the bottom to top. And if let's say you're talking about atrial tachy, you're talking about maybe lower down near the CS there, coronary sinus there. So if let's say this A can give to this QRS, but it won't happen here because there is no P wave here. So you can't be giving the QRS to the next one. Because your atrial tachy, in terms of atrial tachy, your A is a driver. So if let's say there's no driver there, then the tachy should stop there. So, and then clear cut, like what Dr. Faiz has mentioned, you can't see anything like flutter wave here lah. So basically you can rule out atrial tachy, atrial flutter, and AVRT. But the only thing that you can't rule out is your AVNRT, because your AVNRT is actually basically at the in between the atrial and ventricle. It doesn't need the atrial and ventricle, to be honest.
So I think, Chi, you have the privilege to announce the winner.
Actually, I don't have to announce because I think